Okay, good afternoon, everybody. Welcome to, yes, that is the cue to stop talking. So welcome to the January Engel rounds or grand rounds for our faculty here. And today we have Dr. Daniel McFarland. And before I introduce him, I just want to say a few things. One is if you're watching this on Zoom, remember your microphones and cameras are off. And if you have comments or questions, which I hope you do, put them in the Q&A box, not in the chat box. And then at the end, we'll go through as many of those as we can. Also, you'll see the link for the evaluation. Please fill it out today. There might be an email tomorrow with the link again. But anyway, very important to fill out the evaluation. And like I always say, there are plenty of seats open in the front and in the middle of the auditorium. You don't have to sit as far away as humanly possible from the presenter if you actually come in person. So feel free, anybody, to actually get a good seat. But enough of that. So yeah, I'm excited to introduce Daniel McFarland, who's been with us for a few years now. Daniel is an associate professor of psychiatry with joint appointments in medicine and in hematology and oncology. He's the director of the Psycho-Oncology program at the Wilmot Cancer Center here. And he's a medical oncologist specializing in the treatment of head, neck, and lung cancers. I can't recall last time we had an oncologist presenting at our grand rounds, so it's nice that we have him here today. He's also board certified in psychiatry, CL psychiatry, hematology, internal medicine, and medical oncology. So the title of his presentation today is Psycho-Oncology through an oncologist's lens, and we'll hear about that view as well as some of his journey. All right, so I will be back at the end and hopefully we'll have a good discussion.
Thanks, Steve. All right.
All right.
All right. Hi, everyone. This is a research talk, so I figured I would not wear a tie and just kind of dress it down a little bit, sort of be casual. I don't know if that works or not, but we'll try it. Okay. What did I do here? There we go. Oh, it's this one. Okay. So, yeah, I've had an unusual path. I was a PGY-10 at one point. So if you keep on going, you'll I don't know, maybe I'll win some bonus for that or something. I don't know. But what I want to do today is to kind of present this sort of frontline perspective on psycho-oncology, because that has essentially been my perspective. And as we move to the second part of the talk, I'm going to talk about this much intriguing topic of cancer-related inflammation and depression. Okay. Being asked to do this talk, I was just thrilled. So thank you, Steve, and everyone else who was involved. It's been quite a journey. I just want to kind of put that out there. And I was thinking of Lou Alidort, who was a hematologist while I was at Mount Sinai. He would not be afraid to say he had pet peeves every once in a while. And one of them was that he wanted faculty to know each other's research. And because of him and always pimping us and asking questions, he would actually question us on our other fellows' research and everything. So, but I do thank him very much, because when I took the heme boards, I passed because of him. So anyway, just a montage of just wonderful people who've helped me along the way in my particular journey. So 5-year residency, internal medicine, psychiatry. I come to Mount Sinai Hospital in New York City, and I start my first year of fellowship. And to give you a perspective, Chicago is the kind of home of self-psychology. Dr. Harris, if you're listening, he and I, for 5 years, would sit every Friday morning and listen to psychoanalysts talk about self-psychology. Wonderful thing. And boy, did we learn a lot about empathy. So all of a sudden, I'm in this scenario where at this busy hospital. Mount Sinai is essentially like the strong ER, but the whole hospital. It's busy, very talented people, very wonderful place. And I said, you know, the effect of dealing with the trauma, death, and dying, and taking care of cancer patients, I had to wonder what was going on with my colleagues who were doing that. And by the way, you know, when you start fellowship in HEMOC, they're always asking, it's basically the training is half clinical, so 18 months clinical, then 18 months of research. So you're always, they're always being asked, well, what is the research question you want to work on? What do you want to do? Well, the first question I had was, the program director said, we have kind of a problem with our internal medicine residents because all of them are going into CARDS and GI. None of them want to go into HEMOC. I don't understand it. We have all these wonderful treatments these days. And I said, you don't understand it? Have you seen what's going on with them? Because they were, on the cusp of just sort of always taking care of these very sick patients. And so based on, this background of learning about empathy plus theory called terror management, which essentially says when you have a lot of distress and trauma, your empathy sort of narrows. You become a little bit more egotistical, and they sample things, or they give examples of like hate crimes after 9/11 and things like that. And I said, I bet that as these folks are rotating on this service, they may actually experience a loss of empathy if they have higher levels of distress. So it was a pre-post survey that I did, 96 surveys total. And what I found was that the empathy actually decreased. It actually decreased more if they rotated for longer. So 4 weeks instead of 2 weeks. And it was more relevant actually for the female residents and the male residents. And if you think back to, if you're familiar with the research on empathy, in the third year of medical school, there's this decrease in empathy. Now, healthcare, we happen to be a more empathic group than most, but that happens and it's sort of very intriguing, right? And empathy is a sort of a trait rather than a state typically. Now, can we enhance empathy? Yeah, I think we probably can. But what was kind of unique about this was this sort of very acute drop in empathy. And what did that exactly mean? In the survey study, I asked a lot of particular questions that I was interested in. One of them was that if you had a self-ascribed sense of meaning, would that kind of help you in dealing with this? And in fact, it did. So they had higher levels of empathy throughout. And actually, I found that residents were less interested in doing HEMOC. So I think my program directors thought that was kind of an interesting finding. By the way, when you do this kind of work, you always have to get a lot of institutional permission, which I did thankfully get. And, actually the pinnacle of my research career, when I started here, shortly after I started, one of my colleagues in thoracic oncology, Dr. Arpan Patel, I was walking behind him and he actually was telling one of the fellows about my study. And I said, you know what? That is awesome. So if you're listening, thank you, Arpan. And the other thing that I found was that actually there was residents spent less time with patients by the end of the rotation. So they went from spending on average 10 to 15 minutes, this is what they said, to 1 to 5. And if you look at this model on the right, I had actually asked a lot of questions about things that had been associated with loss of empathy, feeling mistreated, unsupported, etc. And this model basically accounted for like 67% of the variance of how much time residents spent with patients. The other thing to note was that this had nothing to do with taking care of dying patients. So on average, they took care of about 4.5 patients who were actively dying. And even the stress from doing that didn't translate into taking care of less or spending less time with patients. But the other thing that was kind of interesting about this was that if they said they had some sort of external issue going on, they actually spent a little bit more time with the patients. You can see the histogram here is showing exactly what I'm talking about. On the right, they're spending less time with patients at the end of the rotation. And so I continue to be very interested in empathy. I had a wonderful opportunity to do a peer support group with my oncology colleagues around the time of COVID, and found that very fascinating. At some point, I would love to continue to pursue this in the form of a Ballant group. I'm not sure if folks are familiar with what a Ballant group is. Came out of post-World War II in England after all these GPs were taking care of very traumatized patients. And I actually participated in one. And what you do is you basically, one of you or your colleague presents a difficult situation. The group asks very clarifying questions. And then, interestingly, you step out and you let the rest of the participants have a conversation about what you just described. And then you come back in. Fascinating, and very helpful. I don't know why we're not doing it more, because I think we should. A colleague at University of Iowa, I helped her with some of her data. And anytime you have data actually looking at providers or practitioners, clinicians, it's a really interesting phenomenon. I mean, it's a new phenomenon if you think about it. This kind of area was very off limits not too long ago. But basically what she was interested in is how am I getting my psycho-oncology referrals? And so it turns out that providers who had higher levels of empathy were more likely to refer patients to their service. Female sex also predicted more likelihood of referral. And their average referrals per clinician was about 8.2, which translates to about 2.1% on average. Believe it or not, the average number of referrals is about 3%. And you think about the level of distress in patients with cancer ranging around 40%, levels of depression across the board around 25%. Now, there are various ways that we address this, but just kind of goes to show we could probably do better. So coming back to fellowship, a lot of symptom burden, and I'll say, as an oncologist, one of the things that's sort of very strange is that you learn all about oncology, which means, which are the best treatments for patients. There's an art to, how long you give the treatment and for whom, et cetera, et cetera. But when you go out and practice, 95% of what you do is taking care of symptoms, of managing patients' symptom burdens. And you think about the training involved in that. It's about 1 month of palliative care, and then sort of see one, do one, teach one, et cetera. It's not enough. And you think about what diagnosis of cancer means for a person. It means the person's life is completely changed. They will always, it's not something you forget. And it changes them in multiple ways. Social system, the way they view life is completely changed. So I was very interested in that symptom burden phenomenon and understanding the relationship between that and psychological symptoms. And what I found, the other part of it was that in our world of psycho-oncology, the most used screening tool globally is something called the distress thermometer and problem list. People have a lot of issues with this measurement, but nonetheless, it's used. And so I thought, the thing is, it's 2 parts, and the problem list doesn't get a lot of attention. And I said, you know what, let me just look at that problem list and look at the associations involved with it. Now, the findings aren't all that surprising, but the reason why I point it out is because, it's something that's a very common measurement. And so basically, moving on from there, I said, if we add up all of these problems that patients have, by the way, even a simple problem like itching or fatigue or these things that are just very common, they're persistent. And so that's the issue. And so, yeah, I could go on and talk about that for quite a while. But there's a theme that I'm going to let you in on here, which is that although patients with cancer often come in and they're very distressed and they're very anxious, the thing that stands out is depression. And so it's always the depression that seems to be associated with poor outcomes, right? And as an oncologist, I'm always interested in those outcomes, right? And I looked at two different disease groups. Of course, breast cancer. At Mount Sinai, we also had this very unique, it was a sort of referral center for something called myeloproliferative disorders, which is a subset of hematologic malignancies that is highly symptomatic, in fact. If you might remember like polycythemia vera, it's a condition where you just itch all the time, et cetera. And this had never been described, actually. And so I was very excited to sort of do that work. Thinking about, we in fact do not prescribe, of course, the majority of antidepressant medications. And we could probably talk all hour about what these different four quadrants mean in terms of patient preference. But I was interested in, how do patients see it in terms of management of their psychological symptoms up front in the oncologist's office. I had actually written a paper called The Oncologist as Therapist because I said, as I went back to training in psychiatry later on to do a research fellowship and a CL fellowship, I said, I just feel like the oncologists don't realize the extent to which they play this role. And so I said, you guys do this through problem solving, through witnessing and being there, and also sort of being the de facto therapist in a lot of ways. So I also looked at early childhood adversity and basically what you would expect. It's very much associated, again, with physical issues and ultimately with depression. And all of this was sort of in what I was really thinking was that, is there a way that we can create some sort of nomogram or predictive model so that, like I was showing you my colleagues' data about who gets referred, could we do this better so that we know who's going to have problems, who's the person that should be seen by psychiatry most urgently? A lot of different questions in the field of psycho-oncology. A lot of it is descriptive. We could talk about all kinds of communication issues. I had a slide that I didn't end up including, but I did a study looking at just basically citations of all the different FDA-approved drugs in oncology. And, the number would be, in the hundreds. And I said, well, for each one of those drugs, how many of them do they talk about any sort of psychological issue? And it was very, very small. I'm sure that's still the same. And, we have this system issue. Who gets to care, right? So we actually did this study looking at how different bone marrow transplant services provide psychological service, right? And it's just so variable, right? So you have a sort of mandate from professional society that says, do this, and we do it in all kinds of different ways. So that being said, and that'll be just an ongoing continuing issue of how do we get patients to care, I also just became interested in depression and survival. So depression, I realized that actually this topic, as you go through and you sort of review all of the stuff that has been done before you, was a little bit taboo. And the reason why was because back in 1989, a study was done at Stanford by Dr. Spiegel. And by the way, Stanford is the home of one of my favorite psychiatrists, Irv Yalom. Sometimes I feel like I want to be Irv Yalom very much. So, I sit and philosophize with patients and whatnot and talk about, freedom and responsibility and meaninglessness and isolation. But anyway, I love their work over there, of course. But the year was 1989. And for the life of me, I could not find the Kaplan-Meier curve here. But I included the title of the work. And essentially what it showed was that there was this very long tail. It was like maybe about 80 patients, in two arms. A control arm did not receive group psychotherapy, maybe resources or whatnot. And then the intervention arm got the psychotherapy. And what they were saying was that the group that got the psychotherapy lived much longer. It's interesting because statistics actually, it's sort of interesting that this was even an issue because there were so many statistical flaws in this study. So Bernard Fox at Penn pointed out all of these flaws. And one of them was just essentially that this was a tail, an outlier group, and then essentially that the control group didn't have that tail. And of course, I don't even think it was powered to look at it. Other people tried to replicate this, and they were not successful. But then actually, Spiegel went back and did the same study. What's really quite interesting about this is overall, the latter study was a negative trial. But what he found in the subgroup analysis was that in the patients who had hormone receptor negative breast cancer, so like triple negative breast cancer, which you may know tends to be a more aggressive type of breast cancer in some situations, those patients actually, the ones who received the psychotherapy, lived longer. So, I kind of think jury's still out. I think there's a lot that happens psychologically, and we'll talk about this in terms of the mind-body connection and that bidirectionality. So, but someday I will read The Anatomy of Melancholy, not the abridged version, but the whole dang thing. And, I'm going to talk about stuff relating to humors, cytokines and all of that stuff, which, both of these entities have been just so mysterious for so long. Let's put them together and talk about them. There's a real tendency in our world to think about this kind of issue as like symptom management. Can we just manage the depression, the anxiety, et cetera? The reason why is because actually when they do that with physical symptoms, okay, and this is work by Ethan Bosch and it's been replicated a number of times, shows that just having early alerts for, hey, I'm having diarrhea, I'm having, anything physically related, shows that survival is better. We've actually done that in Psycho-Oncology through distress screening. Does not translate into better survival. And there's multiple reasons why, but one of them is just, as I was kind of alluding to, our systems of care, right? Like if someone calls in, they say, I have, I'm itchy or I have diarrhea or I'm just fatigued. Yeah, we can do something about that, right? But when you're talking about being anxious, distressed or depressed, the pretext is always death or end of life. There are sometimes stresses involved in surviving. There's the meaning of what you've gone through. And cancer doesn't just affect the patient, it affects the whole social system, the family, et cetera. All of that is disrupted. And so, you have to think about the system, the broader system. This is really what it comes down to. So this is always published by the American Cancer Society, prevalence of cancer, who's dying from which cancers. And really essentially the goal is to kind of go from here to survivorship. Since I've been doing this, I think survivorship's gone from about 14 million to 20 million patients in the US. And it's a very exciting thing, but it is a long road. It is a long road to get from there to here. I just put this up to be obnoxious, frankly, but it actually is a wonderful slide to go through in terms of all of these different interactions, okay? So the tumors themselves cause physical symptoms and related mental phenomenon. And there are just many different ways in which that happens, but so do the cancer treatments. The cancer treatments do essentially the same thing. We try to tease this out. We try to understand what the etiology is. We're not always successful. And so ultimately comes the question, and I think we're very good at answering this question in psychiatry, of let's address what's going on in front of us. And there's many different ways to do that in terms of addressing the emotional problems, or all of these different areas can very much be targeted. So that's why, we talk about constellation of symptoms, et cetera. But again, I come back to the depression issue because of what I've already shown you. And now I'm going to show you actually something much more interesting, which is some survival data. So when I was at Memorial Sloan Kettering, I looked at depression outcome in patients with metastatic lung cancer. And basically what I found was that inflammation measured through C-reactive protein was associated with depression, but so was treatment type, namely chemotherapy, and disease type, which frankly was small cell lung cancer. But when I put this in a multivariate model, it was just the inflammation. Okay, it was the inflammation that was the most predictive of depression. All right, so some of this gets into a little bit of the biology of lung cancer in particular, but I was interested in, nowadays when someone comes in, they have any cancer, frankly, we're doing these molecular analyses that really show us, across the board, irrespective of what kind of cancer it is, what's going on at the molecular level. So this is really exciting because it's obviously predictive of outcomes and response to treatment, et cetera. I looked at what's called EGFR mutated lung cancer, which is a type of lung cancer that in theory shouldn't really have as much inflammation because it doesn't have as many mutations in the cancer cells. And so this was actually a negative association, or negative, I say, negative in terms of like, if they have EGFR mutated lung cancer, they have less depression. What I found was that this is partially mediated through inflammation. And that's about what I'll say about that. But even more exciting is there's this other idea of tumor mutation burden, which is frankly just how many mutations are in the cancer itself. And because I was at Memorial Sloan Kettering at the time, every patient there had this information. And so I could look at that very clearly. This information is predictive for who responds to immunotherapy, for example. And I thought, again, with that idea of sort of creating a nomogram for like, who do we really want to look out for? Patients with a higher tumor mutation burden, probably more likely to have depression because it also signifies kind of more about what the cancer really is doing. And that is exactly what I found, that what's really interesting about this is that both inflammation measured through CRP and tumor mutation burden were both predictive of depression. Now, despite what I said about tumor mutation burden, inflammation, et cetera, this actually makes a lot of sense that there was not a significant interaction. The reason why, sorry, this should be CRP, not CMP up there. But the reason why is because of the immune system. So the immune system, if you might remember, there's the innate immune system and the adaptive immune system. How immunotherapy, there's different kinds of immunotherapies, but the checkpoint inhibitors, which are the one everyone's sort of very interested in these days, works through the adaptive immune system, okay? So creating antigens, et cetera. When we're talking about inflammation and depression, what we're generally talking about is the innate immune system. So something else is actually going on here. In terms of markers, right? Like CRP, not many people get very excited about it, except for me. I'm very excited about CRP. But there are other, what are called acute phase reactants. So these are proteins that essentially respond to inflammation. And I'll tell you right here that actually so I'd been following the psychoneuroimmunology literature for quite a while. And I actually got really excited when I started to see all of this information about CRP. Because, at one time I wanted to be a lymphoma doctor. So I had to learn all of this information about the inflammatory cascades and sort of how the immune system works, et cetera. And it was just funny to me because all these papers are getting information about cytokines, different half-lives, there's diurnal variation. None of it made sense to me. To other researchers either, it didn't really make any sense. But CRP makes a lot of sense because what CRP does is it's an indirect measure of inflammation. So after the pro-inflammatory cytokines, the anti-inflammatory cytokines do their thing, the liver responds through CRP and says, hey, there's a lot of inflammation going on in the body. But that's really what we want to know, okay? And what we're really interested in is not acute inflammation, but chronic inflammation. So yeah, if you're diagnosed with a pneumonia or something and it's acute inflammation, will your CRP rise? Yes, it will. Will you be depressed? No, you won't, because it's not chronic inflammation. And so there are other, so anyway, I got interested also in albumin. So albumin is a negative acute phase reactant. It goes down when people are experiencing a milieu of inflammation. And basically what I found was that albumin pretty much does the same thing as CRP. Now, CRP, albumin, let me tell you why I think this is exciting. So if, let's say you take a group of patients who have major depression, we know, and nothing else, no real medical comorbidities, right? We know that in that group of patients, you're going to have about a fourth to a third of those patients are going to have high inflammation, right? The biggest trial ever done to date, right, is STAR-D trial, right? Where you think about, okay, you start someone on antidepressant, 30, 40% respond, but then you add bupropion or all these other agents, you can get about a 70% response, right? And you sort of have that 30% of patients who are treatment resistant, right? Well, you think about for a second that, this person without any actual other reason for having inflammation, right? The connection with depression and the most abundant protein in your body, okay? So when you spin blood, you take out all the red blood cells, and you have this plasma, there's water in there, obviously, but the most abundant thing is albumin. So you're telling me that if you're depressed, those proteins actually change. I, for one, think that's really cool. And so I kind of started looking at all these other inflammatory markers, and these are things that are sort of like just easy to take. Like, so you have the neutrophil lymphocyte ratio, which is in a CBC. It's simple. People get it all the time, right? And so the idea would be that my patient has a CBC and I'm seeing a high neutrophil to lymphocyte ratio and I'm starting them on some sort of treatment for depression, I probably want to know, like, is there also inflammation going on? So anyway, at this point, I actually started to look at survival as well. And so you actually see that with even this kind of very loose association with inflammation, it also tracks on to worse survival. And then on the bottom, you'll see again that the three curves below are inflammation by itself, inflammation with depression, and depression by itself. Okay, the top curve is folks who didn't have inflammation or depression. I started to do the same things in this patient population as well. The only difference being that I actually started to look at survival again. And if you look on the top over here, it's going to show you that even with all these physical symptoms, let's say fatigue, right? So that's about the 40% increase in worse survival, et cetera. And so again, if this was sort of a split thing where I looked at the number of physical symptoms, and if you endorsed 3 or more physical symptoms, your survival was. Okay. Oops, I'm going the wrong way. We validated a survey study that's called the Sickness Behavior Inventory. And essentially, this in the patient population with lung cancer, and this could be useful. Let's say if you didn't have access to laboratory analysis, and you said, I got this patient in front of me, they're depressed. I want to know if this is an inflammatory type of depression. And essentially, all of these factors load on to the scale itself, which is good. And those factors also load on to depression, measured through 2 different surveys, and then also CRP. But essentially what happens is that if we put for predicting, say, CRP, and we put in sickness behavior inventory, there's an association there. Then we add the depression, then the PHQ-9 is going to fall out. If we do it the other way, then we start with the PHQ-9, and we know that's going to be associated with CRP, but then we add the sickness behavior inventory, then depression falls out. And so this is a way that you regression analysis can sort of validate this scale for what we wanted to do. I also looked at early childhood adversity, again, with that idea of like, predicting who's going to need help. And then now, in this overall cohort of 123 patients, times his diagnosis was about 15 months. Their mean CRP was here at 2.1. 28 actually met depression criteria. They had 79 death events at the analysis. And essentially, I'm showing both at the top that if those patients were depressed, they did worse in terms of survival. If they had inflammation, they did worse in terms of survival. Okay. Now you're kind of wondering, well, again, those 4 different categories. So, you can see over here, in terms of the description of length of days of survival, that if there was an addition of inflammation and depression, they very much had the worst survival. Now, the analysis, the pairwise analysis of this Kaplan-Meier curve or regression didn't actually separate, but you can start to see that it actually was separating. So it wasn't quite powered to look at that. But let me show you some other very interesting things. So if we take that association between inflammation and survival, by the way, I mean, this is well known that, inflammation, survival, et cetera, it's that you're not going to do as well. But what's interesting is that, so if you look at the top here, this is telling us this hazard ratio, 3.14. So that's over 3 times worse survival if you're inflamed, right? But now in this mediation analysis, when you go down 2.85, what it's essentially telling you is that depression mediates some of this survival worsening, okay? Not the whole thing, but some of it. And then in terms of here, in kind of, I had to remind myself about the statistical stuff, right? So, mediation, moderation, what's the difference? And so there wasn't a moderation effect. There wasn't an interaction between depression and inflammation, but this actually makes sense. It makes sense so read my little AI overview over here. So the Cox regression interaction term or moderation assesses if the predictor's hazard ratio varies across a third variable, namely depression, when effect changes. So it's not really telling us when it's going to change, but it's going to tell us how. And then that's exactly what it does. Okay, and so in summary, CRP is a reliable marker for identifying inflammation-related depression. Could be helpful in identifying these cases. And depression is very much a modifiable factor for poor survival. Okay. And I also want to point this out. So I actually, in a subgroup of these patients, did a longitudinal analysis. Now, this is really interesting. So when you look at the 2 time points, what I found was that if the patients endorsed depression at 2 time points, they were more likely to have poor survival. Okay, and that's actually shown in. Sorry, I got these mixed up. Yeah, that's actually shown in the bottom. Sorry, the top is is inflammation. So if at any point they had inflammation, their survival was worse. If at 2 time points the depression was worse, then their survival was also worse. And this tracks with large epidemiologic data showing that is exactly the case, that you could be depressed, but you got to get out of the depression. So if I'm thinking of a large epidemiologic study done by Sullivan, where they looked at, I think it was about 2,000 patients and showed this. And remember what I was saying about the Spiegel study, et cetera. The issue isn't the intervention itself; it's whether or not its depression is addressed. Okay, so it's a very, very key difference. Doesn't really matter how the depression gets better; it just needs to get better. When I was at MSK, I also looked at sort of a very convenient sample of patients that had come into the clinic, and I said, let me look in the, these are patients at a cancer center, so they were going to have a lot of labs done. And it turned out if I could get labs within a week of them being seen in the psycho-oncology clinic, those labs were also predictive of associations with depression. Okay. Now, is CRP the best inflammatory marker? Folks might argue, but Andy Miller and I, we did a systematic review and meta-analysis of all the inflammatory markers that had ever been studied in patients with cancer. Now, there are a lot of other reviews looking at inflammatory markers in patients with depression across the board, but none had been done with just patients with cancer. So this looked at all the studies since like 1970, when this work started to be done. And one thing you're going to see here is going down here, like with the markers, right? Look at the number of studies. Look. So all of these studies, you only have a handful where they've actually been studied a lot. And this is one of the things about the psychoneuroimmunology research is, guys, you're going to draw the inflammatory markers, draw all of them. And that was one of the big points that they made in this research, and why the research has been so messy, as it really has been. But the point here is that IL-6, TNF, IL-1 beta, and CRP were the most studied. And the cool thing about CRP was that, show it here, was that there was very little heterogeneity. Okay, so some of the other ones, there's a lot of heterogeneity, meaning the studies, some could be wildly positive while others were negative. Maybe there's one study that's a little off here looking at the forest plot, but it's mostly, right there. And then you've got, so looking at the effect size of being 0.57, so that's a moderate effect size. So we're basically saying, hey, there's a real association here in patients with cancer. Okay, now I'm going to switch gears just a little bit, and okay, good, I'm not too far behind. And so everything we've been talking about now about CRP is sort of prognostic, okay? So can we move from this prognostic marker to thinking about CRP as a predictive marker of antidepressant response? I gave you a little bit of this background already in terms of just, chronic inflammation, what happens, and why we care about it. So like over here, you might be acutely ill and have sickness behavior. Ooh, I don't feel good. I don't want to go to work today. That's what's happening right here. If that inflammation continues and you really don't want to go to work, and you probably shouldn't, there you go. So anyway, that's what's going on with that. The other part of this work that's really important is the basic science. So because, now if you think about it, everything I've told you about these markers are drawn from the periphery, not the CNS, right? The CNS is always thought of as a sanctuary site, like there's not a lot of immunologic activity there. Well, that turns out to be very much wrong, and there is. And so so I won't go into the details about this, but fMRI data has shown that essentially in the inflammatory milieu, dopamine is depleted in the areas it's supposed to be in, so that's not good. Serotonin is also affected. I won't go into that too much. I like this graph a lot because it's basically taking what is a pretty complicated situation and breaking it down nicely. So, one thing that always comes up is, but what about obesity? What about smoking? What about aging, right? What about all these things, other medical illnesses that cause inflammation? Well, in fact, if you look at smoking, obesity, aging, all of those things have also been associated with depression, right? And the fact is, it doesn't really quite matter why you're inflamed. It just matters that you are inflamed, okay? For the reason that I just showed you. It basically messes with our neurotransmitters, right? And so that's shown through monoamine depletion. It's also shown through glutamate excess, right? And some of these neurotransmitters are toxic to the brain. The reason I like this so much is because what it's essentially doing is like all of this stuff is innate inflammation stuff, okay? And clinically or phenotypically, you've got over here anhedonia, psychomotor retardation, that's depression, right? You've got anxiety, impaired sleep, you could say executive function, you name it. You know, all of those neuropsychiatric symptoms are over there. But what I really like about this is T cell dysfunction. So that's our adaptive immune system, okay? It does play a role, but the role is complicated. It's mostly through the HPA axis, okay, which is kind of going on over here. All right. So if you think about, man, this is an exciting topic, if you agree with me, what do we do about it, right? There's two main things to do. One would be, let's decrease inflammation. The other way to address this is through basically the downstream effects of inflammation. I'm focusing on the latter, okay? And there's a reason why, although I'm kind of interested in the former as well, because drugs like minocycline have also been shown to have an effect on, you know, treating depression. We actually use minocycline all the time in the cancer setting to take care of rashes and things like that. But as you can imagine, it is a little bit got to be a little bit cautious about, say, prescribing NSAIDs sort of indefinitely to treat depression. So I think some of that stuff has yet to really be worked out, but there's a lot of active research there. Moving down to our number 2 thing here, what I want to show you is that, let me move here. This study by Jha, it wasn't a prospective study, it was a secondary analysis, okay, of a study that basically sort of looked at kind of a STAR-D type trial. And the key here is that you see that with patients with low inflammation, right, taking an SSRI, you know, you get 57% response, okay? But what if you're inflamed and you're on an SSRI? 30% response, not so good, all right? But let's say we add bupropion. Well, you go from 30% response to 51.4% response. That's great. And that's the idea. That's the hypothesis, is that in the inflamed state, can we do something more to help patients treat their depression? The other thing that's very interesting here is that if you think about it, this group with the bupropion plus SSRI combination, okay, with low inflammation, why isn't that right up here? Why isn't that right up here? We don't really know, but it turns out that, you know, the same thing has actually been shown when you give like, you know, like those rheumatoid arthritis drugs that sort of knock down inflammation, like really knock it down. Yeah, their depression outcomes are not great. They're actually worse. And so something's going on with that. And so there's kind of a newer way of describing this, which is, if you think about it, it could go both ways. You could say, in the inflamed state, we need to add bupropion, because why? Well, bupropion is a drug that we have that repletes dopamine, right? What else do we have? Some other things for Parkinson's and whatnot, but that's what we got, and we use it, and it seems to work. It seems to work particularly well in other scenarios. We use it for fatigue, etc. But the way that this is kind of being described now is in terms of the SSRI, or sorry, that the SSRI is more effective in the non-inflamed state, okay? And that's important because it means that, you know, is it bupropion? Is it, you know, one study looked at nortriptyline, one study looked at duloxetine, you know, and found that in the inflamed state, those non-SSRI drugs do better, but they do worse in the non-inflamed state, okay? So it's kind of a bi-directional thing. So the study that I have been trying to push along, okay, there it is, for a while, I'm going to get to in a second. This is an awesome paper I found. So we always think of like antidepressants, there's no head-to-head trials. Well, there are. I mean, most of the trials have been against placebo. But this was important for me because I wanted to see that if there is any difference between bupropion and its side effect profile and its efficacy profile versus a very standard drug like escitalopram. Turns out there's really not, so pretty good choice. Okay, so I took this idea to one of our cooperative groups in oncology and said, hey guys, if you care about depression like I do, then maybe we could do this trial that uses C-reactive protein as a predictive marker of antidepressant response. And so this schema was, well, it was vetted, and basically what it does is you would have a patient who comes into the oncology clinic with depression, and the oncologist says, okay, we're gonna start some treatment, right? And by the way, this would all run in parallel to whether they were going to send you to psychiatry or do yoga or other things that might also be helpful. Patients would be randomized to inflamed or non-inflamed, and then they would undergo another randomization to bupropion versus escitalopram. The design here was problematic for one particular reason, and I knew about it from the very beginning. I should have pushed back, but they really wanted this design because it would have given us a very large sample size, 428 patients. The problem was the cut point at 1 CRP of 1. Now, this was sort of extrapolated from cardiovascular data, right? We just don't quite have enough behind us to say that this is really the cut point that we should use. So, back to the drawing board a little bit. And this, what we're calling adaptive approach, would be something where, same thing, patient comes into the oncology clinic, they're depressed, the oncologist starts escitalopram, and at 6 weeks, basically looks to say, are they responding? And if they are, great, continue the escitalopram. There's going to be a significant number who are not, and so then they would be randomized to escitalopram versus escitalopram plus bupropion. And then the study would go on for another 12 weeks, looking at kind of all the standard stuff. And the other part of this, although I didn't put up all of the aims and objectives in here, you can imagine what they are. Obviously, the primary outcome is remission from depression. But the other neat thing about what I'm talking about, if you think about it, is I'm asking the oncologist to prescribe the antidepressant medication. When I presented this to oncology groups, they said this, I think I could do this, but won't you teach me something about prescribing antidepressants? Let's make this a little transactional. So anyway, I'm hoping to move forward with this at some point, and I cannot believe it that I have actually finished somewhat on time. So thank you guys so much for listening.
All right. Thank you, Daniel. That was really interesting. Really got a good chance to see the kind of intersection of psychiatry and oncology.
Yeah.
So that's fascinating.
I got a chance to review it too. It's just fun. Yeah.
That's always good. Yes.
You don't remember what you've done, right? It's like,
We count on you being the expert, so you got to keep up on the literature.
I was like, oh, that was a really good idea.
Okay, so do we have any questions from the audience? Okay, well, while you think of a question, we have a question from Zoom attendee. So thank you for taking us through your prolific research program that truly lives at the intersection of medicine and psychiatry, or more fundamentally, physiology and behavior. I especially appreciated your reflections on Ballant groups, patient preferences in depression care, and your attention to how mental health and social care are often sidelined in our systems. Your work on predictive inflammatory markers is very exciting. Okay, looking ahead, how do you see psycho-oncology helping reduce disparities for patients with severe mental illness And where do you see the most important opportunities right now for stronger bridges between psychiatry and the Department of Medicine?
Oh, absolutely. So, and this is a very much kind of an issue that hasn't been addressed well by psycho-oncology, I would say. I think there's a way to do this. I'll tell you what I'm thinking is that there's a movement in psycho-oncology to use collaborative care models, which Dr. Nazra, you're still here now. But anyway, this is a very specific kind of triaging mechanism, okay? And one of the things about it is it's supposed to be equitable in terms of, basically finding patients sort of up front. I think that, that's also great because it's measurement based and we can really keep track of these patients. I actually looked at our data here at Wilmot in terms of patients with SMI and found that although I think, gosh, I could get this wrong. I couldn't believe this number when I looked on the website. It was like 45,000 patients, new patients a year. Okay, well, I looked at every disease group that we have, lung cancer, heme malignancies, et cetera. What I found across 5 years was about 100 patients who have serious mental illness. Our colleague Kelly Oberman was just here last week, and she gave us a really good presentation at Wilmot about SMI and cancer. I disagree with her a little bit on one thing, which is that her contention was that these patients are here at Wilmot, for example, but they are not being seen, The reason I think that's problematic is because, we know what their medications are, right? We would have some idea, I would think, right? I don't know if I believe the data that I found, 100 patients per year, but it kind of tracks with what we're seeing. I mean, we have a kind of international collaboration about this. We're writing a book about SMI and cancer. I have a review paper coming out in SMI and cancer. This is pretty consistent. So what it says is that there's two issues. One, when the patient gets diagnosed with cancer, we're dropping the ball. Problem is, if you're at Wilmot, I only see patients once they're diagnosed, worked up, and they've gotten the right scans and all of that. Those are not patients, if they have schizophrenia, they have good family support, they've been well controlled. And this is pretty much what my colleagues' experience is, right? And so, it's a matter of capturing those patients. There are going to be some patients that honestly, it's, getting to cancer care is complicated. And we're only making it more complicated. And what's happening in terms of equity is that gap is widening because now our treatments are even better. So that means the fact that you didn't get immunotherapy and there's a chance that duration of response could be really long, that's a problem. It's different than the old days where, okay, didn't give you 2 months. Okay, maybe no big deal. This is a big deal, but it's really, really hard to get patients. Now, inevitably, not everyone is going to get to treatment, but that group in the middle is so key. And I actually think there's two things. There's what Kelly's work did is looking at patients who've already been diagnosed. As I said, Wilmot isn't seeing those patients. So that's on us. It kind of comes to mind, is psychiatry a primary care discipline? Yes or no? The travesty is that if you think about it, all SMI diagnoses, bipolar schizophrenia, serious major depression, they're diagnoses that happen early in life. So those patients have been interfacing with psychiatry from age 19. They're not getting screened. They're not getting necessary medical care, period. We don't know where they are. I mean, from an academic medical center, I don't know where they are, right? They may be getting seen in the community. They may be getting seen elsewhere. But I told you, those are the patients that we see. They're doing well from a mental illness standpoint.
Okay.
Sorry, I didn't mean to go on a tirade, but just, go ahead.
The problem is that oncology has evolved so fast and so massive that there is a language problem. There's a language problem between medicine and psychiatry. There's a language problem between oncology and the rest of medicine. We don't speak the same language anymore. And I think there's a fallacy that patients with severe mental illness, even if they have cancer, can go through cancer care without us even knowing what that means in their particular cancer, right?
Yeah.
So I think that there needs to be more talks and more education about what we can do nowadays with people with severe mental illness. And we need to do more research on severe mental illness. Like you, I worry that we're not screening enough people. And that we're not screening them soon enough, because if they died 30 years earlier, they should not be in the same screenings schemes as other people.
In fact, studies have shown that distress screening doesn't work as well for patients with SMI for whatever reason. I don't know why, but clearly the system is failing them, and it's a travesty because again, they've been interfacing with the system for a long time.
Just as a final thought, we do have a medicine and psychiatry primary care clinic located over at Strong Ties. And
all right, I'm coming for you, MIPS.
Okay,
coming for you.
They do see people over there with cancer, so that could account for some of the discrepancy.
I know.
But okay, we are definitely out of time now. But thank you, Daniel, and that was really an excellent presentation. So remember to fill out the evaluation.